Hello! Hi, you're here. So now we are going to read Gallstone Ileus in Schwartz, Principles of Surgery, 11th edition, and you will find this on page 1409. Let's start. Gallstone Ileus. Gallstone ileus can occur when a large gallstone erodes through the wall of the gallbladder directly into the intestine via a choledochoenteric fistula. These stones can then pass through the intestinal tract until they reach an area of fixed obstruction. Proximal stones can become impacted in the pylorus or proximal duodenum, causing gastric outlet obstruction. They call it Bouveret syndrome. Those that travel distally may become lodged at surgical anastomosis or the ileocecal valve, where they can become impacted and cause small bowel obstruction. Gallstone ileus is responsible for less than 1% of all intestinal obstructions. These patients present with symptoms of obstipation, nausea, and abdominal pain. Plain films may show an obstructive bowel gas pattern but may fail to identify a radiolucent stone. Ultrasound evaluation may be limited by extensive bowel gas. CT is highly sensitive and specific for gallstone ileus and will help to determine the location of the obstruction. Management of the gallstone ileus focuses on relieving the intestinal obstruction and removing the gallstone. In cases of very proximal obstructions in the stomach or the duodenum, endoscopic retrieval can be effective. For more distal stones, surgical enterolithotomy can be accomplished either laparoscopically or open. This procedure entails the removal of the stone through enterotomy that is then either repaired or resected depending on its size. Stones that have successfully traversed the ileocecal valve are likely to pass without further intervention. The role of pursuing cholecystectomy and or choledochoenteric fistula closure at the time of enterolithotomy or addressing it at later time remains a topic of debate, but it should be considered to reduce the risk of recurrence. So that's it for gallstone ileus from page 1409 up to 1410. Thank you.